Hello, I'm Jim Hamilton, former international rugby player, 15 years professional. I played for Scotland for 10 years, former athlete. So I'm an aging Mac. I'm 42 years old. I'm really interested in human optimization. And there's also a big elephant in the room when it comes to the sport that I played around concussion and the lack of treatments and TBIs and the effects that the sport has had on not just me, but many others. So I'm in Dallas, home of the Dallas Cowboys with TriSelect, which is actually on the campus of where the Dallas Cowboys train. I'm really excited to show you what they're doing at TriSelect. I've got two legendary doctors. I've got a good friend of mine who's a former USA Eagle. He's South African, but he's from the US as well. So I can't wait to show you. So I'm going to get them to do the introduction because I can't do them justice. So docs, work your magic and tell us what you do.
I'm a board-certified neurosurgeon. I did my internship at Cleveland Clinic, my residency in University of Louisville, and my fellowship from Johns Hopkins University. I've done quite a few things. I hold plenty of patents from the US. I did the first ever spinal cord stimulator along with the chairman of my department to allow a patient to walk again. It was University of Louisville, and first ever robotic spine surgery in the state of North Dakota, first ever robotic spine surgery in the entire Middle East and Africa was done by me in Abu Dhabi a couple of years ago. So I've done quite a few innovative things, and I'm very passionate about exploring the role of stem cell in helping in a variety of neurologic conditions, and we can talk in detail in a bit.
Yeah.
My name is Dr. Sudhir Raburi. I'm a stem cell and healthy aging researcher and scientist here, and I'm working as a director of the research and development at the TriSelect, focusing on adipose-derived stem cell biology and application and translation. And we're also looking into the healthy aging diagnostics, the preventive and the predictive diagnostics and management.
So my name is Jean Grobler, also ex-international rugby player, played professionally for 10 years. I have a science degree, so this topic really interests me, along with how we can basically give back to guys that we've played with and look at solutions that I don't think are available to rugby players nowadays. I'm very, very interested to look at the treatment program surrounding stem cells and open up a whole new field and explore some of the cutting edge technologies that TriSelect offers. The interest from my perspective is that, ex-former rugby player, some dementia in the family, some, concerns about how many concussions we had during our playing days. What does that look like when you retire? What are the markers? What can we do to prevent what I think a lot of people don't really want to talk about? So I think it's very interesting from a scientific background to have, top-end doctors discussing, what the options are treatment-wise, what some of the biomarkers look like in detecting concussion, and what is concussion. It's a very, very touchy subject to talk about. Nobody really wants to address it. It's like the big white elephant in the room. So let's talk about that and what can we do as former rugby players and how do we help our mates? You and I obviously have a lot of former players that have concerns, post-careers. And then how do we help the young guys that are coming up and playing now that have concussion after concussion? What does a protocol look like in helping those guys get back on the field, So, Dr. Baker, maybe you can start off and tell us a little bit about, first of all, what is a TBI?
TBI stands for traumatic brain injury. And there are many different types of severity of TBI. It's typically classified as mild, moderate, and severe. Concussion typically, for the most part, falls under mild. And the way we define mild in current, language that we use amongst the neurosurgeons is through Glasgow Coma Scale. It was actually from Glasgow that this measure.
Glasgow?
Yeah, that's
Scotland.
Scottish.
Let's go.
Glasgow.
Sorry.
So smart people call it.
So I'm not that smart. He's smarter. But in that sense, it looks at 3 different parameters. It looks at the eye function, the verbal function, and motor function, the capacity to move. So if your eyes are spontaneously open, you're engaging, you have the highest score. If you're talking to me properly without any confusional state, you got the highest score. And if you're moving your arms and your legs to command, you got the highest score, which is 15. And the bottom score is 3. You can't open your eyes, no matter what anybody does to you. You basically can't talk, and you're not moving anything. So current state of definition of mild, moderate, and traumatic uses that, but there are a lot of other criteria that we are starting to use that gives it a more specific kind of severity that we can somewhat use in a predictive way to say, hey, this person is likely going to do well, this person is not going to do well. You asked a lot of very important questions, and we'll get into a lot of details. But I want to just define things so people understand what is it that we're talking about.
So would it be fair to say that the concussion is a symptom of a TBI?
Concussion is a manifestation of TBI. So just like you have a condition is has occurred due to something else, a predisposing factor. So it manifests as concussion. So you have concussion if you have injured the brain and you may have lost consciousness, albeit briefly. It still may be called concussion. Some people are trying to shy away from the word concussion because it's vague. It's not very definitive. It's not very specific. So that's why we use other terms to kind of objectively classify the severity of traumatic brain injury.
Can you see, like, if somebody's had a concussion and you do a CT scan, can you see an actual concussion that just occurred?
No. Vast majority of patients who have concussion, which is mild traumatic brain injury, their CAT scans are normal.
So how do we detect it? How do we see it? How do we know that someone's had a concussion?
So a lot of people have done a lot of work on this, and there are other objective diagnostic tests like an MRI, depending on the severity of the traumatic brain injury. Some can manifest signs, what's called diffuse axonal injury, which can be picked up on certain sequences on MRI. And Abbott has come out with a couple of tests, 2-factor tests. One is testing the neuron, which is the electrical conduction of the brain, which is a short-lived high spike event that can be picked up through a blood test. And there is also a structural protein with the glial type protein, which sort of lingers a slightly longer period when if you do the test. If these are above a certain threshold, then there is high likelihood that this patient has suffered a traumatic brain injury.
So it sounds like, from a layman's term, that would be considered like a marker that you can pick up in a blood test. So you're looking for like a protein that's
Yes.
different from other cells that are in there that would show that you have a TBI.
Yes. So that's an acute traumatic brain injury. Now, patients who have had CTE, this is a term that's tossed around. It's chronic traumatic encephalopathy. Encephalopathy is an insult to the brain. Anything that damages the brain, infection, brain tumor, injury, oftentimes the most common thing is injury, trauma to the brain results damage to the brain. And when you have chronic traumatic encephalopathy, which means you've hit your head once, you've hit your head twice, you've hit your head multiple times, that is persistent injury to the brain, it manifests in a certain way as you age, and rightfully so. Your concern for dementia is a very legitimate concern. 85% of Alzheimer's is not genetic. So about 10 to 15%, you can say, well, chromosome 21 is tied to that, but vast majority of it is not. There are vascular causes, traumatic causes. What it is there are multiple factors, but one of the factors that we know for a fact is deposition of plaques and abnormal substances that the brain just does not know how to get rid of. So it accumulates inside and it causes cell death. As it causes cell death, the density of the brain shrinks and you kind of get dumber and dumber as time goes by.
So is there a number you can put on, like, how many concussions would it take to get to the CTE stage?
No, the problem is some people have a lot of injuries to the brain and they still are diagnostically completely normal. Other people get one hit and they're abnormal. Some get a double hit phenomenon and die. So it's really hard to predict because there are genetic factors of healing. Some person, you can literally run them over with a bus and they'll stand up. Hey, what's next?
Right.
Other people, if you barely touch them, and they fall apart. So there are acquired factors and there are genetic factors that we don't know entirely everything about. So to predict how they'll do. Yes.
So that'd be a really important thing, wouldn't it? Around who, I don't know, no one's built to take contact. It's not what humans need, but in the sport that we're in, that's what happens. You look at boxing, you look at UFC, obviously NFL would be the main sport around that, and then rugby, our sport. So there's no way of showing how susceptible someone would be. There's no tests, there's no scans, there's no profiling. Because I think it's really interesting from my sport, and like there's a lot of players like the NFL that are going through tough times, and there's going to be players coming around the corner as well. From my generation, where we've taken numerous head trauma, some bad, some really bad, and some micro concussions, because that's the nature of our sport. But then there's players from Samoa, Tonga, Fiji, who skeletally are built very different. South Africa. Are there studies done on profiling human beings, on bone density and these kind of things?
I'm not aware of a study that differentiates different segments of population and their sort of propensity to injury to suffer brain injury or spinal cord injury. But what we do know is athletes are in much better position to heal faster because they're in prime state. Their muscles are strong, tendons are strong, ligaments are strong, and they're aerobically active. Even if you were to do surgery on athletes, they bounce back real quick versus the same surgery done on a non-athlete, their recovery is very prolonged. So certainly, athletes have an edge. Some are gifted because they're coming from a genetically superior pedigree. Others acquired, they push themselves to compete with the others who are genetically have an edge. But athletes have an edge and they do better compared to others. But we don't have a specific predictive way to say, Jim, if you go in there, bang your head with 1,000 force, whatever, Newton, that you're likely to have mild traumatic brain injury and not a severe one versus, John, or vice versa. So there isn't such a thing. And I don't think it's a practical way to look at human beings, because as we evolve, every generation, there is mixing of genetic pool. And you may be an active person, but your kids and your grandkids may decide to lead a very sort of stagnant lifestyle, and then you can't expect to have the same kind of response if you were to have a trauma.
Maybe just explain what a trauma looks like specifically in sport. So what happens to the brain when there is a big collision, maybe what happens when there's a small constant collisions. It's maybe good to educate people on, like, what are we dealing with here? Because this is the elephant in the room, right? You play a contact sport, right, where humans aren't built to do like that. That's effectively.
So when you're young, you have a fixed size skull, and when you're young, the entire skull is filled with three substances: brain, spinal fluid, and blood. So literally there's no room, no wiggle room, okay? So when you have a trauma to the brain, a few things can happen. One, you have direct hit to the brain, injury to the brain, okay? And that's the first phase. That injury could simply be a physical injury or an injury that then leads to bleed, which can be outside the brain, like a covering called dura, epidural bleeding, which can be lethal. Within 15 minutes, a person can die. Or it can be subdural bleed, which is above the brain but under the dura, or which can be inside the brain itself starts bruising and bleeding. So that's the initial insult, initial sequela. The secondary insult is What does the brain do at the end? Well, now the brain is dealing with the injury. Brain is very gifted, and it's got very intrinsically controlled environment where, something that is in your bloodstream may not make it to the brain because there's a special blood-brain barrier to protect the brain because that's the master organ. And at the same time, the brain has an intrinsically controlled environment to only be fed by glucose and a constant supply to keep the brain functioning. And the regulation of blood volume that goes into the brain, out of the brain, strictly regulated within the brain, unlike other organs. So when you have an injury to the brain, that mechanism of autoregulation is messed up. The area of the brain that was supposed to get specific amount of oxygen, specific amount of nutrient, is no longer getting it. So then cells start dying. And when cells start dying, the body needs to find a way to get rid of the cells, and it starts expanding. Remember, skull is constant, brain is full in a young brain. Now you have no room. The pressure inside the brain starts building up. And sometimes the pressure builds up very quickly. That can result in a person dying. And other times, slowly enough for us as physicians to pick up on clinical signs and symptoms of abnormality that we jump in and do something. If it's a bleed that is big enough causing compression, patient is comatose, we go in there, take the pressure off. And sometimes we actually take large chunks of the skull out. We either store it in the person's belly or in the freezer for several months. And then once the swelling goes back down, we bring back the skull and reconstruct it. Other times we just give them some drugs to kind of decrease the flow to the brain so the volume inside the brain goes down. Indirectly, it decreases the pressure inside the brain, which helps with the recovery.
So, Doc, you mentioned that in a young brain, like what is a young brain?
Well, it depends on how we define young. I think in my book, young brain is a brain that is between 15 to 30.
So you're saying
young.
as you age, your brain gets smaller and
Absolutely.
you have more room?
It physically gets smaller. And for people who drink alcohol, it shrinks at a faster pace compared to a person who doesn't drink alcohol. So it basically means that the cells are, the brain cell, alcohol is a neurotoxin, is toxic to the brain cells, so the brain cells start dying off. So if you're concerned about dementia, one of the first things you can do if you're concerned that you have encephalopathy due to injury of the brain through rugby, drop alcohol.
Thank goodness we've given up alcohol, Jim.
Yes.
Yeah, that's the first step in the right direction, right? So this concussion affects people in different ways. So as I understand it, if you have an impact, it can affect Jim differently than it can affect me. Is that correct?
Absolutely.
And so in thinking about that, is there a magic number of concussions that any one person can have during your career?
No, because you can have a bad enough first hit that can kill you. We have plenty of evidence of second hit phenomenon where it has resulted in death.
Right.
And we also know plenty of people who've been hit all day long and they're still lingering. So
Jim's still with us.
So what's the secret sauce? I mean, we don't know. We don't know. There's honestly, we have some evidence, we have some supporting evidence that we can say these are the factors, but nobody can conclusively say if you get one concussion, you're gonna die, or if he gets 500 concussions, nothing's gonna happen to him. We just don't have that data. We have some evidence. I mean, less concussions you have, the better. Less trauma to the brain, less likely that you will result, it's gonna result in encephalopathy. If you have less encephalopathy, less chance of you developing dementia and Alzheimer's. These are facts.
Right.
But to quantify specifically on a person, right now, I don't believe we have that data.
Gotcha.
And what is the effects of the trauma? So you think after a career as an ex-athlete ages, headaches, forgetting stuff, the depression and anxiety that maybe comes off the back of that, dizziness, and then everything above that's worse. I'm sure there's a load of other symptoms along that. So is that the damage that's kind of been done? Is that the inflammation of the brain before? Maybe just try and explain what that and how them issues
Sure.
present themselves.
So there's acute post-concussion syndrome. You've just been hit, and then you can have a variety of symptoms. You can have bad headaches. You can be nauseous. Your personality would be different. You may have sort of difficulty with balance, dizziness. You may just have, your mood might be off. You may have apathy. So you may act like a sociopath during that process. And then as time goes by, typically symptoms get better for most people, and some symptoms linger longer than others. What we can say is the more often you have these injuries, these manifestations get worse. So if you are having some of the symptoms that you described, depression, personality change, just feeling like brain fog and cognitively not at the top, as time goes by, these symptoms actually get worse. So it's just a sequelae, a delayed sequela of early multiple brain injuries, which dementia is one of them.
So, Doc, explain to us, like currently, what's available out there for treatment for ex-rugby players outside of, stem cells, which we're going to get into and talk about.
So typically, standard treatment, if you've had a traumatic brain injury, you go through rehab. What does rehab mean? Well, you'll have physical therapists working on gross motor function to make sure all the limbs and everything's firing fine. You have occupation therapy, the fine motor function and hands are protected. You get certain exercises. Speech therapy, along with cognitive therapy, is critical. They want to make sure that your comprehension of speech is intact, and how you respond to speech, which is motor speech, is intact. And are you behaving normally? You get neuropsychological testing. All these are sort of treatment options that are available. Sometimes you can get some stimulants to kind of see if it'll boost your thinking process.
But does any of that stuff actually work as far as
It does.
healing you and getting you to a point where you're regenerating neurons or
No.
or fixing an existing?
No. So what these things do, they create a bypass pathway. So let's say you are going from point A to point B through this route. This has been injured. Now the brain starts developing new synaptic activity to bypass the site of injury. But not everybody can do that. Some people have bad enough injury that area is dead and there's no coming back. So, but typically, brain, that's the purpose of rehab, is to create that bypass pathway so they have a chance of regaining some of the function that they've lost, either due to trauma, stroke, tumor, you name it.
Gotcha. So as we've understood and uncovered, you guys are on the cutting edge of a potential solution with using stem cells, and maybe explain to us, or explain to, in layman's terms, what stem cells are we using, how do those work, where do we get them from, etc. I mean, that's a multifaceted question, but
What is a stem cell?
what is a stem cell, and how do I go get one? I put it in my brain if I'm a rugby player, right?
So there are multiple sources of stem cell. Stem cell is it's like a baby cell that gets external signal to then modify to become whatever it wants to become. If you have a stem cell, a baby cell, it's hovering around cartilage, and with the right type of signaling, it becomes cartilage. If you have a stem cell that's hovering around bone, it modifies itself to become bone. So multiple sources. There's embryonic stem cells. There are embryos that have not been used that could potentially be used for a stem cell. There's a lot of ethical questions about using embryonic stem cell. I've never used them. I don't intend to make that part of my practice. There is bone marrow derived stem cell. You can actually get bone marrow, your own bone marrow, autologous, spin it down, harvest stem cell. The volume of the stem cell, the durability of the stem cell is not the best. You can also get stem cells from fat tissues, your own fat tissue if you're young, or you can get fat tissues from other young people, spun it down and stem cell and use it. Or you can use umbilical cord derived stem cell. And these are all different sources of stem cell that are used in wide variety of therapeutic reasons for various conditions and have shown promising results.
And today, you earlier on, you described stem cells as almost like a tree. And explain a little bit, expand on that.
Oh yeah, definitely. So I see a stem as a stem cell as a tree. It makes branches out of the tree, out of the stem. That makes a complete tree. So the stem cell is also something like that. So stem is make a stem cell, like Dr. Baker mentioned. So it takes the form of a heart, a skin, or bone, or cartilage, whatever. So that is a stem branching out. But we see a branching out into different types of cells, cell types. We call them the phenotypes. So stem becoming a cartilage cell. So yeah, so like that. So we make a complete tree, but different branches from the stem.
Gotcha.
And why with stem cells are we so new in this space? As an ex-athlete, I've heard about stem cells for years. I know this is specifically around brain health, but for injuries for knees, shoulders, necks, we're hearing like UFC, NBA, NFL, soccer now. They'll go to Mexico, they'll go to Germany. So we're in America, land of the free, home of the brave, but also of innovation as well. Like, why has it not taken off here? And it's probably similar to the UK, that you're just given an anti-inflammatory drug, or they'll just give you a new metal knee and be sent.
Well, the MSC is an anti-inflammatory, correct?
It is.
Yeah,
Absolutely.
So why is it taking so long? So when this has been in the works for so long and so many people are speaking about it, why has it not taken off? Like, why is everyone not here? Why is this place?
Was it a regulatory issue?
Acute out of the door.
Yeah, good question. Number one, like a scientist and a physician, they're trying to understand the biology of different types of stem cells, like Dr. Baker mentioned. And then, like, drug has a specific dose and then the response, but stem cells, the lot of number of stem cells, type of stem cell, the administration of stem cells, and the disease condition that we're treating into. So those are all factors matter when taking a decisive approach to treat the disease condition. And of course, the regulatory, so the safety and efficacy. Those are the factors adapted to make sure the product is being giving a safe outcome. And the stem cell is also is kind of an old approach of dealing with the conditions, but the biology is ever evolving, so is evolving day by day, and then we're turning to learn more things. Now, we have bad cells in stem cell, like a zombie cell concept, now coming into, and then more cells is bad, less cells is good. These kind of studies are coming up all over the world. So we need to find a sweet spot, what is required for number of cells, disease condition, what is the outcome. So that's why a lot of regulations are there. And in addition to that, safety of the patients is really important, an outcome.
So given that, are there any side effects to ex-rugby players receiving stem cells?
So the application of stem cell from vast majority of the studies have minimal to no adverse action. There was a recent study done, a 10-year study. They've analyzed 11 big studies that have already been done with almost 500 patients in the study, and the 250 plus patients actually receiving stem cell, and in the control arm is 153, zero adverse action and traumatic brain injury, and with positive neurologic outcome after getting stem cell therapy.
So how would we receive the stem cells? Is it intravenously? Is it?
So again, there are multiple modalities of stem cell. You have to ask what type of stem cell you want first, how many cells you want, and what are we treating. This particular study, majority of the patients received intrathecal stem cell, which is stem cell injected within the spinal fluid, which circulates between the brain and spine.
So that's like a lumbar puncture.
Lumbar puncture, you inject it in there. Because if you were to give an IV, and some studies have shown that if you do an IV, the efficacy is the same as intrathecal, but this particular study did intrathecal because there is the concern that the blood blood-brain barrier needs to be bypassed in order for the cells that go from the blood vessels into the brain. And if there is any issues with blood-brain barrier, not enough cells will get there to get you enough of a therapeutic result. But these studies were done with intrathecal injection, and patients did well.
And you also looked at intravenous
Intravenous.
stem cells. So then how does the stem cells know where to go within the body?
Interesting. I mean, some of the patients who received stem cells, had a patient who got, he had, shoulder pain, knee pain, hip pain, neck pain, back pain, and got 1 dose of IV stem cell, all his pain went away. So, and then if you have a patient who comes in and say, hey, my knee's really hurting me, so there's no point in giving you systemic stem cell, just give it to the area where the patient is suffering. This gentleman came to me who was basically limping on one of the knees and needed surgery, but said, I don't want to have surgery. I got 1 dose of stem cell. The following day, called my office and asked me, hey, can I go running? I said, absolutely not. 6 months out, he's doing great. Now he's going to come back for a shoulder injection. So,
So Jim, it sounds like a carbon copy of any old rugby player limping into a clinic with everything wrong from the little toe all the way up to the head. So what you're saying is you can get almost a magic bullet as far as MSC stem cells.
yes. So we have to
can
be
fix multiple problems
Yes,
within inside and
we have to be careful that not everybody gets the same result. That's the variability factor that we don't really know. You could get a stem cell and be a super responder, which would give you very positive result. That means it could almost bring you back to normal. He could get a stem cell, he would be better, but you may not have the same response as you. I could get a stem cell, it may not do anything for me. But what we do know, most patients who get it do better.
Interesting.
Yeah, some people listening or watching this, the reservations would be to have someone else's stem cells or from an umbilical cord put into them as opposed to their own. Like I would feel much more comfortable personally having my own put in, but
Sure.
just a little bit more around
Sure.
how that's regulated.
Very, very, very legitimate question. So, if you're young, your stem cells are young. If your stem cells are young, they'll do their jobs, very well. But if you're old, your stem cells are old. If you use your own stem cell, well, the efficacy may not be as good as a young stem cell. There is legitimate concern. I don't want somebody else's stem cell coming to me. What if there's a reaction? Interestingly enough, in order for the cell to recognize that this is, let's say, Jim's cells get into my body, just average cells, my body has a mechanism to recognize that his cells are foreign. They'll kill his cells right away. And there is a specific manifestation, a marker on the stems, on every cell that his body is expressed, except stem cell, that will tell me that it's Jim's cell. But stem cells done right, harvested right, processed right, his stem cell coming into my body wouldn't be able to detect it because that marker is missing.
So you're not going to grow into a 6'9" giant.
No. And that's why this was a concern a lot of people had. And then, interestingly enough, there were no adverse events for that. And
So it's not like a blood type where you have to get the same blood type
exactly is that
to receive something.
Yeah, HLA marking, the major histocompatibility complex, which is a very specific thing that we look for to define something as foreign. That's not present.
So as you age, do you lose then stem cells, meaning you have less and less MSC or mesenchymal cells as you get older?
Yeah.
So then it would behoove you to take cells from a younger person and put them into you?
Yep.
And there's no adverse effects and it can go to an area? And
So I refrain from saying no adverse effect, because anything, you put an injection into anything,
Right.
that you can expose the bacteria getting into the skin that can cause an infection. You're careless about where you put the injection, you could injure a blood vessel and cause bleeding.
Sure.
So I don't want to say no adverse. Anything you do, anything that's therapeutic, potentially could have. But the safety profile is very, very good of stem cell compared to just about any drug you take over the counter.
So it's not like one of these drugs where you see an advert and there's like a whole list of side effects.
Yeah, nothing like that.
Gotcha.
And does it regenerate? So if someone came in through the door and they have symptoms that we've gone through, and they go to a stem cell program, does it reverse those symptoms?
So stem cells can do a lot of things. We're learning more and more. It has anti-inflammatory function. It has regenerative function. It has function to replace cells that have been damaged. So growth hormone is one of the premier hormones that is anabolic. It increases the metabolic rate, and it's got a lot of positive effect. It sort of kind of goes hand in hand with that type of hormone, all the positive effects of that. And the recent study that was done in Mayo, where they had patients who were paralyzed, 1 year out, they were not moving their limbs, and they harvested fat-derived stem cell and injected it in the spinal fluid. 70% of them got better.
Well,
It completely, really allowed us as neurosurgeons to rethink our answers to patients' questions. Can I get better? Because traditional thought was, if the brain is injured, it's injured for good. If the spinal cord is injured, it's injured for good. So what is the rationale for these cells that are not supposed to get better to get better? So obviously there is a missing link that we're coming to find out more about, and it's really amazing that such an option is available. And I think with time we'll likely get to a spot where we can give predictably good results to most people who have these problems. And we here in TriCellix can easily replicate that 10 patient, because right now on my Instagram, I got lines of people who are wanting to get stem cell therapy for a spinal cord injury. And we're planning on getting the IND from FDA and being an FDA approved lab here to allow for these patients to come here in Dallas, Texas to get the treatment.
Gotcha. So it sounds like there's like a twofold or a couple of phase approach. So somebody comes in that's just had a TBI or a concussion potentially. How do you treat that person? Do you give them treatment, stem cells right away to prevent inflammation, and then is there a second phase, like a subacute phase where they would get
I don't want to steal Dr. Rivera's thunder, but I'm going to briefly mention this, and I'm going to leave but I think he's done a lot of work in what we call senescence. So there is a concept that there are stem cells that are within our body, are quantitatively there, but qualitatively absent. What does that mean? It means that they're there, instead of generating the positive signals that the cells are supposed to give for healing and improvement and regeneration, it starts giving negative signals, pro-inflammatory signals. So, and then they become dead weight. Now we have at TriCellix a proprietary product and products that can eliminate these zombie cells, so that when we do give the stem cell, the potency of the stem cells would be very powerful and the response be more robust. Sorry, you can explain that.
And explain what is senescence to
Thank you, Dr.
Gemini. We don't know what senescence is. Explain to the viewers what that means.
Yeah. So when a cell goes wrong in a body, so that cell has to die, and that's called as a self-death of the cells. And that's called as we call it apoptosis. So, but when a cell becomes very bad, and that cell, when the cell escapes that kind of self-death mechanism, that is called as senescence. So senescence means cell, instead of dying, it becomes bad and then stays bad without dying. So a dead cell living in the body. So that's called as senescence. So we can quantify these senescent cells in percentages by using different modalities, like specific marker, like gene expressions, and there's protein expressions, and also cellular expressions or cellular profiling. Right. So we can quantify these cells. The concept of senescence is, as the Mayo Clinic and other reputed institutions, they define the researchers, the senescence is considered as the nexus of all disease conditions. So it converts the pre-existing conditions and also it can track the other disease conditions. Say, like Dr. Baker mentioned, these stem cells can repair a mechanism. So we go one step further in calling these stem cells. We call them as the scientific field calling them as medicinal cells or signaling cells or mesenchymal stem cells or or medicinal signaling cells. So those are universally profiled cells that can escape the human immune system, so to fix the body. So when the senescence is more in our body, so the repair mechanism goes down. So what we discussed, the age factor goes high. I mean, aging will cause the depletion of stem cells. So it's not like so cell number going down, but also whatever the cells are there, they lose their rejuvenation potential to make the branch into stem into multiple branches. So what we are trying to do at TriCellX is, so we're preparing a stem cell product, medicinal product, or signaling product, the allergenic product from other patient, and a pure product. But before making a pure product, we want to make sure that product is enriched. So how we can enrich the product from a donor is to prepare the donor with all.
Someone like Jim, would you have like a bunch of dead cells floating around in him?
Yeah.
That you'd have to get out before you put in the new young
Good
cells.
cells, yeah.
Exactly.
And then you fix them.
Say, for example, if you're being a donor, so if you're donating something, so we want to get this medicinal cells, but those medicinal cells should be clean. So we treat the body, with the agents called as senolytics. Senolytics means that can kill specifically these senescent cells in the body.
So is that a simple blood test to identify how many dead cells you might have in your system?
Yes, the simple blood test can give us the answer how many senescent cells are there in the body.
And then you put someone on a program that cleans all that out before you get the MSCs?
Yeah, so we do a simple blood test for the senescence profiling, to measure the senescent cells, and then we adapt a period called as a senolytic therapy. So that is with the senolytic agents. That agents are prescription drugs or natural supplements. They can specifically kill these senescent cells in the body. So when we go with this kind of treatment, and then after that we harvest the medicinal cells, mesenchymal stem.
How long does that period take?
That depends. So usually people have been showing good results from 1 month or 2 months of treatments. The animal studies says even shorter. So that is what we are developing, a comprehensive testing and then comprehensive therapeutics to prepare the donor to get an enriched product. At the same time, when you have the enriched product, and then when someone comes with a recipient, then we have to make sure that recipient is also clean. We don't want to put an enriched product in a bad body.
Right.
So we want to treat them with the senolytic therapeutics, then prepare them and to get these enriched product into this. So this way, both ways of preparation with the donor and also recipients to handle that process called as a senescence.
Good.
And then we could reduce pre-existing conditions and also reverse pretty much of the conditions. And
You got to watch out, mate. There's a sniper out there when you say things like that.
yeah,
You know, I'm like, right.
Doc, what's the process then? So if people are watching this or listening to this, and then they could be in desperate measures, they could be thinking further down the line, what's the process like? Do they just pick up the blower, give Catherine a ring, and
Yes, call us at tricellx.com and we'll take it from there.
and then how does that process look?
It really depends. What is it they're wanting, and what are we treating, and what's our end goal? And we have a lot of products in the preventive state. We have products in the diagnostic states. We have products in the treatment phase. So what is it that we're after? And we're aspiring to be a company that's an end-all be-all for all aspects of regenerative care. And we want to allow patients to live longer. We want to allow patients to be more functional for longer periods of time. And we want also allow patients to gain the years that they've lost due to smoking, other adverse action, trauma, and so forth. And there is evidence that we can do that.
So, Doc, we hear of friends of ours that have gone to maybe Germany or, Mexico to receive stem cells. And what's the benefit of TriCell X or coming to Dallas to come and get treatment?
Sure. Very powerful question, and I want to really take my sweet time answering this. So when you go to place A and get stem cell therapy, so-called stem cell therapy, let's call it Mexico, and you get no response, your immediate answer to that would be stem cell therapy does not work.
Right.
You step back and ask, where did you have that therapy done in Mexico? Do you know if the cells that were injected in you are viable cells or not?
Right.
If you can't answer that question, then you're just not giving stem cell the right chance it needs. How many cells were administered? What is it? What was treated? How was it injected? Where was it injected? So all these questions have to be answered right for you to get the right response. It's almost like I'm a world-renowned mechanic that only works on engine. Mm-hmm. You have a transmission problem. Right. You come to me and I redo your engine, make it look squeaky clean, so powerful, but you can't shift the gear. Now, did I do you any good?
Exactly, no.
No, so you have to have all the points in place. So if you go to Mexico or Ukraine or some random country to get stem cell therapy and you don't know where they got the cell,
right?
We here at TriCell X, in association with UT Southwestern, are going to have a specific qualitative way to ensure the number of cells that you're going to be receiving, qualitatively that these cells are viable. And you want that kind of response. And we want to be nothing but quality for everything we do here.
So earlier on, you'd mentioned like expanding some of these cells, like some of these clinics will expand them a number of times. Yeah. And then you talked about the actual MSC cells that you would then receive are non-expandable. Yeah. So tell us a little bit more about that and what does that mean? And
so stem cells are hard to come by. So they're, again, you got to have enough fat to harvest to get certain number of stem cell. You got to have enough bone marrow. And you can't just drain your whole blood to just get stem cells, or else you got to live, Right. And there's only a finite amount of, umbilical cord floating around. So what do these labs do? They bring the cells, and then they start regenerating the cells, generation 1, 2, 3. What we're finding out is after you regenerate them or make them grow twice or 3 times, everything else beyond that, these cells qualitatively are not the same. So the response of these cells is not as powerful as the primary organic stem cell that you've freshly harvested, either from umbilical cord, bone marrow, or from the fat cells.
I'll add a couple points to Dr. Baker's. When we have the cells culturing in the lab, say we're causing a relative aging in the cells. So although the cells are from young individual, but when you culture them, they age faster. And then not only accumulating the relative aging in those cells, but they also lose the potency. They call it a rejuvenation potential or regeneration potential or the differentiation potential. Like all we're talking about the stem becoming branch. And when stem fails to become different kinds of branches, then it's no good from that stem. So they lose that kind of potency. And that's what Dr. Baker is referring to. So we make sure the safety, the efficacy, the rejuvenation potential of the stem cells. So we produce an enriched product. So that's what our goal is with an evidence and evidence-based science that we have.
And being a neurosurgeon, you've obviously looked at a lot of different brains, cross sections, and so would you be able to look at someone coming in prior to what their brain looks like, and then post using some of these stem cells? Can you see
again
differentials in that?
Not really, because for you to have structural volume gain with stem cell, I've not seen any evidence in any study that have done that. And for that to happen, you have to have massive change in structural function of the brain, because we know that the brain shrinks. We know that the cells die as we age, and yes, these studies have shown improvement, but the improvement has not been to the point where you can actually see the results, pre and post MRI, pre and post CAT scan, the volume. But here's a tricky part. We know for fact that as we age, our disc height goes down. It's a given. Ask any neurosurgeon who's done spine surgery. What's interesting, injection of stem cell in the disc space with moderate degeneration, with height loss, we have for fact seen the disc height regain, which has blown us away. Our largest organ in our body that is not vascular, that does not have direct blood supply, is disc. And this disc, as it goes down, it just keeps going down and gets worse. That's why people get, pain in their leg, back pain getting worse. But injection of stem cell into the disc, we have seen regeneration of the disc height, and compared it with patients who've had surgery, and the results were similar. So if I were to come to you and give you a choice of having surgery, put a bunch of screws and rods in your back,
Right.
or potentially get you an injection that could potentially allow the height of the disc to be regained, which one would you choose?
Yeah, obviously they're non-invasive.
Yeah, because the risk of an injection going in the disc is a lot less than
Right.
getting spinal fluid leak, getting infection, bleeding, possibly getting worse. And, screws can be malpositioned. You may need a second surgery. And oftentimes when you do fusion surgery, there's a concept called adjacent segment degeneration, 3% per year, that you are looking at least 5-10 years down the road needing another surgery.
Right.
So that cycle keeps going on and on. And after doing 5,000 surgeries, there's got to be a better way to help people.
Does that transfer over for rugby guys as far as you blow out a knee, an ACL, an MCL, a meniscus?
So you got to be careful.
And now I've got to go for a surgery to repair that.
So I think we have to be very clear about the role for stem cell in regeneration. So there are structural components that you can't live without. So if all your ligaments that keep the knee attached to each other are torn, you can't expect stem cells to have everything, because these are all structural components. They have to have the strength and integrity. But if you have mild injury that does not affect the structural integrity of the knee, and you would consider trying stem cell over surgery, that might be reasonable. But I wouldn't go out of my way to say the stem cells at this stage would replace structural integrity of the joints in the body.
What about like an AC joint?
Again, so if you have AC joint mild disruption that is otherwise intact and you want to give stem cell a chance, then that's a reasonable thing. That it can potentially, it's a single joint, you allow it some time to heal, and then regeneration occurs, and you may not need anything done. Certainly a lot better than putting steroid in that joint, which is anti-inflammatory, but it also has a lot of deleterious effects in recovery of that area. And we know for a fact that it actually causes tendon damage and other damage. So I'm not a big fan of steroid.
So things like arthritis, what does it do for arthritis?
So it's the same thing. What is arthritis? It's inflammation of the joints. So if you have, what we know, that if you catch a person in the moderate phase of degeneration of arthritis, that they get the best result, because the structural components are still there, and then the stem cells adds on to the structural components and expand. The tricky part comes if you are bone on bone. Now what you got? Even in that state, patients who've had injections have gotten better, but how long? The duration then is lower than a person who gets an injection, has structural components, then the therapy is a lot longer. The stem cells work for a lot longer.
Interesting.
Last question from me. How is this received from a government level, from sporting organisations? I know the military are making big plays in this space for the quality, the longevity, and the support after war for for their veterans. How has it been received across the globe?
So there's mixed responses. I mean, obviously, this is not a topic that pharmaceutical companies are eager to entertain because that affects their direct bottom line. If you create an organic solution that is very powerful and potent and makes people get better without taking drugs, then that takes away revenue from them. From a military standpoint, I think we're likely going to get a Department of Defense contract to help military veterans who've suffered traumatic brain injury, give them a chance of recovery through our program. And there are people out there who want this available, and we're just having to go through this investigational new drug treatment program with the FDA to get registered, be FDA registered lab, so we can make that available to as many people as possible. And as we gather more information and if it's consistently good, hopefully get an approval formally and make it available to everybody in the world.
Yeah, sport, NFL, NBA, UFC.
So right now, nobody's come out of their way to say, hey, let's just use that. But we're hoping that we can share our success story with as many people as we come across, that we can have them change their stance.
Yeah, so a lot of these athletes, are they going rogue when they go to Mexico and they go to Germany?
Yes, because they're wanting stem cell treatment, but again, they don't know any of these specifics. They're just going to a random lab and then getting something done, and then they don't get better, and then they come around and tell their buddies, say, hey, that didn't work. But they never bothered asking what exactly was it that they got, how many cells was it, were the cells alive when they got it, where were the cells harvested, and so quality is everything.
And with TBIs, what are the other alternatives? So we're looking at this and we know there's a desperate play, especially in our sport, for a solution to help these people. What else is there out there?
I mean, there are lots of experimental things that are being done both in the country, in the Caribbean, and so forth, in Mexico. I don't have enough information to substantiate the validity of or success rates of these. But stem cells, I mean, we're just following evidence. It's published data, and anybody can look it up and see that the trend is consistently positive with this type of treatment.
But I think we can all agree there's a desperation for a solution, right?
Correct.
I think
Yeah,
we know that.
100%. And would it behoove you guys, or do you, as TriCellX, do you have plans to conduct like a big clinical trial and get rugby players in and then really, dissect what you can do for them and then publish those so that more people can come and get treatment?
We would love to collaborate with anybody who's willing to come forth and work with us.
Very good. Closing remarks.
Dr. Baker mentioned, so we are collaborative, and also we are conducting a small study within our institution, within our TriCellX, and then we're also developing the INDs for.
What is an IND?
It's an investigation new drug or device. So with stem cell, it is could be what we are calling it as a TriCellX non-expanded mesenchymal stem cells or mesenchymal medicinal cells or the segment cells. So that is a product that we're developing, and for that product to test that in the patient population, we need to get an IND from FDA. That's what we're working on. And in parallel, we're doing small clinical studies also.
So in a clinical trial or study, is there a magic number of how many participants need to be in that?
There's a power analysis that we need to do. So it depends on what kind of groups we are categorizing the patients into and how many should be, so that we design the study based on statistics. And then we go with eventually we need to draw some statistical significance. So then we design based on the power analysis, and then we go with a number of the patients.
Gotcha. And Doc, if we have 10,000 rugby players lined up outside the clinic here wanting treatment, can you handle those?
We might need to arrange logistics before we can say we can handle all of them, but we're willing to work with anybody who's willing to work with us. Let's put it that way.
And you'll plan to expand clinics? Does that go into Europe, or is that just
so at least our plan is to have other centers within Texas and a couple of centers in Florida, a center in Dubai, center in Saudi Arabia and Qatar, and one in London, hopefully. So goal to hit at least 20 centers in a short period of time.
Are you shying away from Glasgow?
I don't know.
I'm East Coast, not West Coast. So that was great.
Cool, guys. Well, thanks for your time and thanks for educating us. And we look forward to getting some treatment.